Hello and welcome to the Kinepict Knowledge Bait podcast. I am Christian Szigeti, CEO and co-founder here at the Kinepict. Every month we are going to be welcoming guests from with lots of different aspects of medicine to talk with us about the best practice and new innovation in the industry. Today we are welcoming Bala Nemes from Semmelweis University, who is the head of the Department of Interventional Radiology. Hello Balázs and welcome.
Hi, nice to meet you.
Please tell us briefly about your work. What kind of cases do you treat during your clinical works?
I am an interventional radiologist specialized in vascular interventional radiology. I do peripheral cases, mostly revascularizations, sometimes embolization for acute bleedings. I work in a close collaboration with the Department of Vascular Surgery, so I'm receiving most of the patients from the vascular surgeons for endovascular treatment.
When and where did you first encounter the CO2 angiography? Um, what do you think? When, what kind of patient should it be used?
Actually, from a few colleagues of mine, I heard CO2 as an alternative contrast material for a certain patient group. The problem was always how to work with CO2. CO2 is, of course, invisible, and if you try to inject CO2 into the vasculature, there is a high chance that it will be contaminated with air, and that will cause an air embolism at the distal vessels. So CO2 is good because we can treat patients who are not good candidates for iodinated contrast material angiography or interventions. We had always also problem that how to inject it, and we had the chance to see Dr. Manzi in Abano Terme several years ago, maybe 5 years ago, and he is a prophet of CO2 angiography. And there was a special company, it was an Italian company, Angiography, who produced special injector and all of the stat what you needed for CO2 angiography. So we decided to start using CO2. Why we need CO2? Because the ionic iodinated contrast material has a risk for renal failure in patients with limited kidney functions. And unfortunately, with the increasing number of diabetic patients, the likelihood of decreased renal function is higher. And actually, the majority of the critical limb ischemic patients are diabetic. And we know that the occurrence of contrast-induced nephropathy significantly increased in patients with a bad GFR, which is less like 30. And we had to treat these patients, and there is no way to avoid nephropathy if you use iodinated contrast material. CO2 is a good alternative for those patients.
You mentioned that the iodine contrast media is very harmful to the kidney. What does the scientific literature say about how common is the kidney damage from iodine contrast media?
We have data from the literature. Actually, I checked it before. And there is a special patient group when you have to save the patient's life. And it doesn't really matter how much contrast you use. And those are the patients with acute coronary syndrome. And the literature said that patients with acute coronary syndrome has contrast-induced acute kidney injury in 6 to 15% in different articles. So there is a high chance in normal patient population that the patient can end up with a kidney injury because of the contrast material. Unfortunately, nowadays the majority of our patients are coming with critical limb ischemia, and as I mentioned, critical limb ischemia is very common in diabetic patients, and in diabetic patients, again, the renal function is really far from optimal. So if we treat critical limb ischemic patients to save their limb, we can expect a higher contrast-induced kidney injury if you use iodinated contrast media. So there are certain drugs, there are certain methods to try to decrease the injury, but actually there is no way. Whenever you inject contrast material, the damage is done. So if you can avoid it and you can replace the iodinated contrast material with something else, that's beneficial for those patients because you can do a very complicated procedure and you won't harm the kidney of the patient.
If I see a lot of different published journal, I think so the penetration of the CO2 angiography is very low. What do you think why?
One factor is how to inject it and how to avoid air contamination. We have the solution for that. Another problem that CO2 as a negative contrast agent works really. It's non-allergic, non-nephrotoxic. It has low viscosity, so it can go really through very small side branches. We can use it to inject contrast CO2 contrast through a microcatheter, which is quite difficult if you use iodinated contrast material. The problem with the CO2 that it has a smaller density if you compare to iodinated contrast agents. So the achievable image quality is lower, and it is a really important limiting factor. To obtain good quality images, it's very challenging. You have to use a high resolution DSA system, of course, and you have to use image stacking. So that means that we need and requires a higher frame rate, up to 7.5 frame per second, which means increasing radiation exposure, which means a lot of images acquired and a lot of post-processing needed just to be able to produce a good quality image. And that's a major limitation, I think, and that's why even at the beginning of our practice, we were really reluctant to use it because we felt that it needed a lot of work after the image acquisition just to be able to produce a good quality angiography.
Can you tell us a case where you use a CO2 angiography?
Usually those are patients when we try to avoid nephrotoxicity. Those are patients with a GFR less than 30. Actually, if you are about thinking just the diagnostic angiography, of course, if you have a patient with a limited kidney function, you cannot do CT, of course, because there is only iodinated contrast material available for CT. You can use DSA, but in the past we used only iodinated contrast material. Actually, there is a special MR sequence when you can avoid giving any kind of contrast material. But if you have to treat those patients, and those are most of the cases, critically ischemic patients, which are really at the verge of amputation. So if you have to treat those patients, there is a big chance that the patient will end up with a kidney failure. So the question, what should the patient lose, the kidney or the affected limb? So in these cases, of course, we switch to CO2 because you can do the whole procedure, or most of the procedure with CO2. You can use a lot of CO2 contrast during the procedure because the patient will just breathe out. So whenever we will have a difficult revascularization case, when we had to do a lot of imaging during those procedures, there is no way to use contrast materials. So those cases are reserved really for CO2 injection and CO2 angiography during the procedure.
You tell us an interesting story, and you mentioned a lot of disadvantage of the CO2 angiography. What do you think? How can you increase the image quality or solve this kind of problem of the poor image quality?
We started to use the CO2 injection for those patients with depleted kidney function. The company who is producing the injector what we used, Angiodroid, recommended to use a high frame rate angiography just to acquire enough images just to be able to produce a good quality angiogram. The problem that if you use that one one angiographic run goes up to 100 image frame. And of course, if you have more frame rate, that means you will have more radiation for the patients and the doctors and personals in the angiographic unit. Luckily, there was a new study at the Semmelweis University. Those started as animal studies using digital variance angiography. Two young guys were really curious what we can do, how we can use, what kind of results we can achieve with digital variance angiography. We started with animal studies. We tried to decrease the radiation dose. We tried to decrease the contrast media quantity, and we realized that even with decreased radiation or with decreased contrast media, we were able to achieve good quality images. So the next step was, why not to try digital variance imaging with CO2? And it was really a breakthrough because we were able to acquire good quality images with that post-processing. And we realized that the high frame rate, which was needed for the DSA, we just switched back to the 2 frames per second from 7.5, and we were able to produce the same quality imaging. And actually, we have a brand new unit with a huge display, which can be divided. And whatever images we produce or post-process with the DVA, we were able just to put in front of the doctor to the screen in a real-time manner. So that really made a big difference in our daily practice. With the increasing experience using CO2 as a contrast material and the tools which make CO2 angiography easy and comfortable, we have a chance to replace iodinated contrast material in our daily practice with CO2, because we shouldn't forget iodinated contrast material is nephrotoxic. So if we can replace it with something else, it's beneficial even for patients with normal kidney function.
Thank you to all our listeners for joining us today. And a big thank you to Balázs Nemes from Semmelweis University for sharing your insight and wisdom with us. As always, if anyone has any questions or comments about the things we have discussed in today's podcast, be sure to get in touch with us. Looking forward to catching you all next time when we welcome another inspirational guest to the Kinepict Knowledge-Based podcast. Bye.
Goodbye.